back to the floor pretty soon here.
Yep.
So firstly, we have our stage 1. So I just want to make you aware that, even our biggest pressure injuries, the one that go all the way down to the bone, that are really big and scary like this, they all start out just like this, just as a stage 1. So what is a stage 1? That's when there's no break in the skin yet, but there is a little bit of redness, maybe a little discoloration in the skin, but also keep in mind that redness is not the end-all be-all assessment finding for a stage 1. So if you have somebody with a really dark complexion, don't rely on color change alone because you may miss something like this. You want to get your hands involved and feel the skin. Sometimes you can just feel a change in the consistency of the tissue, the temperature of the tissue. It may be warmer or it may be cooler than the surrounding tissue. So definitely feel the skin, because you may be able to find something like this even before there's a color change, even in somebody with fair skin. So there's not yet a break in the skin. Let's see what else. Yeah, it can appear differently in somebody with darkly pigmented skin. So this is the non-blanchable test. So that's when you see a reddened area, you want to push into it and release your finger, and you should see a flash of white. But again, this isn't always true, especially in somebody with a darker complexion. So it is an assessment finding, but it's not the only assessment finding. So yeah, you just want to push into it and release. You should see a flash of white. All right, so I've got a few questions for you today. It should just be fun, and for learning purposes, if you don't get it right, that's okay. So take a look right here. Which one of these would you say is a stage 1 pressure injury? Am I hearing number 1? Excellent, number 1 is the correct answer. Yeah, because number 1, you can tell it's localized. It's definitely over bony prominence. This is on the left hip, over on the left trochanter. I don't know what happened. It did say left trochanter, but I don't know where the trochanter went. But that is a bony prominence, so I definitely would be suspecting that this is pressure related. Number 2, there's a break in the skin, so it's no longer a stage 1. 3 is a little bit more, it's too diffuse. It's not localized like a pressure injury. That is a good example of venous dermatitis, so not a pressure injury at all. And then the bottom right one at number 4 is a little bit more ominous. We'll talk about that stage in a little bit here. So here's our stage 2. So stage 2 is a partial thickness wound, meaning that it's a very shallow open ulcer. So when I say partial thickness, what that means is it doesn't extend beyond the dermis into the subcutaneous tissue. To give you a visual, it looks much like this wound right here, where it's very shallow. It's like if you had a fluid-filled blister and it ruptured, what you would be left with underneath. It's a very shallow opening that we're talking about. Your epidermis is about the thickness of a piece of paper, and your dermis is about the thickness of a credit card. So imagine those two stacked on top of each other. That's about how deep a partial thickness stage 2 pressure injury is. If you have anything deeper than that, it's likely not a stage 2. And what you're looking at here anatomically is the dermis. So a lot of times we see documentation errors where nurses will say this is 100% granulation tissue just because it's red. But what you're looking at is the dermis. It's not granulation tissue. We only see granulation tissue forming in full thickness wounds. So just be sure when you are documenting something like this, not to say there's any granulation tissue, slough or eschar. Slough or eschar are also full thickness tissue types that should not be found on your documentation of a stage 2. You should also know that a stage 2 pressure injury can also present as a fluid-filled blister. So if you have a fluid-filled blister and it's definitely pressure related, it's over bony prominence, we're suspecting it's pressure, it would be correctly staged as a stage 2. Even though that the skin is not ruptured, we know that epidermis is dead. It's hanging on, but it's no longer viable. So if it were to rupture and slough off, what you'd be left with underneath is a stage 2 pressure injury. Okay, so take a look here. And I'm just going to preface this that all of these patients are bedbound. They are not up and walking around. But if you found the following wounds on your bedbound patient, which one would be a stage 2 pressure injury? Or a good example of stage 2 pressure injuries? Number 1? yeah. So the only reason I said that is because this guy has shoes on, and so I would be thinking that this is more friction related, and it likely is in this picture, but that's a really a good picture of what a stage 2 pressure injury would look like. It looks very much like a ruptured blister. 2 is a little bit more jagged in appearance. So can anybody guess what 2 might be? It's a skin tear, exactly. Yeah, good. So that jagged appearance, you can almost see where that flap of skin got torn away and replaced. Not a pressure injury. A lot of times people are tempted to choose number 3 though. What do you guys think number 3 could be? Yes, excellent. Very good job. Yeah, this is a moisture-associated skin damage. These 2 get commonly mixed up. A good way to tell the difference is that moisture-associated skin damage is much more diffuse. So it's way more spread out. I can't really tell where it starts and where it ends very easily. That's kind of a good indicator that it's more due to moisture and less due to pressure. Pressure is a lot more localized, much like in these, these examples on this model here. They take out like kind of a clear punched out appearance of the bony prominence underneath the tissue. So it's almost always kind of a localized, clear, punched out type of wound, whereas MASD is way more widespread. And 4 has a lot of necrotic tissue on it. We can't clearly stage that, so that's not the right answer. Okay, again, yeah, so if it's not granulation tissue, what do I call it? I like to say red, pink, visible dermis, just because anatomically that is what you're looking at. But here's some other examples of what you can say. You can just describe it as partial thickness, and just say that it is moist, pink, red tissue, for example. If you forget all of those terms, you can just say it's red, non-granulation tissue, and that's perfectly fine as well. All right, so take a look here, fact or fiction. Diffuse denuded area to bilateral buttocks should be documented as a pressure injury. We kind of just went over this. Yeah, good, right? This is not a pressure injury, but let me ask you this. Can it turn into a pressure injury? Yes, absolutely, yeah. So they did a study pretty recently of across 5,000 patients in a long-term care facility, how many of them with MASD turned into a pressure injury, and it was around 27%. So it's a pretty good turnover that we see if we're not careful. So definitely want to treat this and prevent the skin from breaking down. So moisture-associated skin damage is an umbrella term, really. It means any type of disorder that is caused by excessive moisture and breaking down the skin. So we get a little bit more specific. Incontinence-associated dermatitis is what we see in this picture here. It's a subcategory of MASD. So if you want to be even more specific in your charting, you can use incontinence-associated dermatitis. Just be sure that the patient is actually incontinent before you call it that. But if they are, and it is due to the incontinence, that's a very specific term that you can use. Also, another term that you can use to elevate your charting and your wound care terminology is intertriginous dermatitis. You may have heard that shortened to intertrigo, and what that is it's a moisture-related fungal infection that happens between the folds of the skin. So, if you lift up somebody's breasts and you notice that there's like a kind of a itchy, like moisture-related kind of rash underneath the breast, that would be a good example of intertrigo, or what we call intertriginous dermatitis. Oh, okay, here's another question for you. I'm sure you'll be able to answer pretty easily. Open reddened area to the right buttock should be documented as moisture-associated skin damage. No, what clues you in about this picture that it is not moisture? Well, MASD can be open and red, right? Oh, I see. It's localized. Exactly. Yes, that's the correct term. It is localized. It's over the right buttock. If it were moisture related, it would be everywhere that the moisture came into contact with the skin, right? So usually on bilateral buttocks or kind of in an equal distribution, but not on just one side like that. Yeah, it takes on kind of the appearance of the bones underneath, which is a little bit more circular and punched out. So yeah, I would definitely suspect this is pressure. All right, so let's talk about the stage 3. So sometimes people feel a little bit confused by the stage 3. Like they get to, 1 and 2 are pretty easy, but somewhere, between 2 and 4, it gets a little confusing. So let me help you kind of figure out how to clearly define the stage 3. So the stage 3 is now full thickness. So the stage 2 is only partial thickness with that depth we were talking about the piece of paper over a credit card, right? Anything beyond that, so long as you don't have any exposure of deeper anatomical structures like bone, ligament, cartilage, muscle, fascia, if you see any of that, it's got to be a stage 4. But if you don't, and it's definitely deeper than the stage 2, you're probably looking at a stage 3. Some other clues is that you can have fat exposure. So if you see adipose tissue, that's a good indicator that it's a stage 3. If you see granulation tissue, does anybody know kind of how to tell the difference between granulation tissue and dermis? What does granulation tissue look like? What was that? Yes, exactly. Yeah, it's bubbly. It's kind of more three-dimensional in appearance than just your regular dermis. So if you take a look at this model again, the dermis is a little bit more flat. It's pretty flat, just like your skin, versus granulation tissue, and especially in a live patient, it's much more obvious. It has like almost buds to it, or bubbles, like you said. It's cobblestone appearing. It's kind of like got grooves to it. That's what granulation tissue looks like. So if you do see granulation tissue, then you're looking at a stage 3. You can't have granulation tissue in a stage 2. And also in a stage 3, if you see slough or eschar, I mean, if there's so much that we can't stage it clearly, then that would be an unstageable. But if there's a little bit of slough or eschar, that's another good clue that you're looking at a full thickness wound, since you can't have slough or eschar in a partial thickness wound. So the depth of the tissue damage varies by anatomical location. So we'll talk about this a little bit more when we have the stage 4 come up. But on the bridge of the nose, for example, or behind the ear, are very areas that are very thin skin already. So you can have a stage 3 that's not very deep. But if you do, you can tell by looking at this picture that the granulation tissue is a little bit more, there's a little bit more three-dimensional appearance to it. There's almost like a lip in the back there. You can have undermining or tunneling, but again, you don't want to see any of those deeper anatomical structures like fascia, muscle, tendon, ligament, cartilage, or bone. All right, with all that being said, take a look at these pictures here, and which one do you think is a stage 3 pressure injury? Which one? The second one? Yes, second is the right answer. Yeah, sorry, I think the 1, 2, 3, 4 got missing on this one. So number 1 is definitely not the right answer, right? What do we see in smack dab in the middle there? Yeah, definitely some tendon or ligament, something there. Something that we know it's a little too deep for it to be a stage 3, right? And then 3 is a little bit too dirty. It's covered in slough. I don't know what's underneath that. It's not safe for me to stage that. And the bottom, the 4th picture right there is actually a venous ulcer. So it's just there to show you that something can kind of look similar to a pressure injury, but I'm glad you didn't fall for it. A good clear indicator of why that's not a pressure injury is it's not over the bony prominence of the ankle. It's a little too high on the ankle, which is a little bit more classic of a venous ulcer. Number 2 is the correct answer because the granulation tissue is more bubbly in appearance. You can even see some adipose tissue exposure. So our stage 4, way easier to diagnose than the stage 3, in my opinion. Just because if you see any of that, boom, it's a 4, yeah. Bone, tendon, muscle, fascia, ligament, cartilage. Do you guys know what fascia is? No? Fascia is, it's a fibrous casing of our muscles. So it almost looks shiny in appearance. It's like this thick kind of fibrous tissue that contains our muscles. But if you do see fascia, that means that it's a stage 4. So a lot of people think that it has to be bone. It does not have to be bone. It just has to be one of these deeper kind of musculoskeletal structures. So you can have slough and eschar just so long as it's not so much that you can't see the depth of the wound. You can have what's called epiboline, which is rolled edges in the wound. You can have undermining or tunneling. And just keep in mind that we don't do any downstaging in pressure injuries. So if you do have a stage 4 pressure injury, it will remain a stage 4 until it's healed. And even after it's healed, if it reopens again, it's a reopened stage 4. So our pressure injuries always remain the deepest stage that they ever were. We don't like, next day it's looking better. We're like, oh, today's stage 3. We don't do that. Okay, so here's that example I was talking about where stage 3s and 4s are not always deep. It can vary by anatomical location, especially on the bridge of the nose. If you see the bone, it has to be a stage 4, even though it's like not this huge, deep wound like we imagine when we think about a stage 4. And same thing with the back of the ear. Even if, it just took, a few hours for it to develop, but you can see cartilage, it has to be a stage 4. All right, so take a look here. Which one of these do you think is a stage 4 and why? Number 1. Good, number 1 is the correct answer. What do we see there? It's bone, yeah, Some shiny white bone that's in the middle of that wound, and yeah, it might be a little bit more obvious in person. So yes, definitely stage 4. Number 2 is another good example of a venous ulcer. Just there to show you other things can be full thickness. It doesn't mean that they're all pressure injuries. That's a little bit more widespread, and the location alone tells me that it's a venous ulcer. On the bottom, number 3, that's gonna be, can anybody guess what that is? On the bottom of the foot. What is it? Diabetic, good job. Yeah, diabetic foot ulcer, excellent. They're even missing some toes, which clues you in. Number four is a good example of a stage 3, but I would want to investigate that further. I would want to get a cotton-tipped applicator, and I would want to feel in there and make sure that I can't directly palpate the bone with a cotton-tipped applicator. If you can't see it, but you can probe it very easily, then that is a stage 4. But if you can't, which I'm assuming you can't, then that would be a stage 3 if you couldn't probe it. So we have a special stage which we refer to as the unstageable, and that is for any reason that we're not able to see the extent of the wound. Most often it's because there's too much slough, too much eschar in the way, but it can also be if you have a non-removable medical device. So if somebody has a splint that cannot come off until like ortho takes it off or something like that, but we know from the history that there is a pressure injury underneath it, we document it as unstageable until it can be visualized. Deep tissue pressure injuries, previously known as DTIs. Have you guys heard of DTIs before? Yeah. Well, the National Pressure Injury Advisory Panel recently popped in the P for pressure. So now it's a deep tissue pressure injury, DTPI. You can still call it a DTI, but if you want to be most up to date, most correct, it's a DTPI. Just because people didn't think that DTIs were pressure injuries, so they're saying, yes, they are. And they are a form of an unstageable pressure injury in a way. So we'll talk about that in a minute. So yep, if you can have an unstageable, there's a non-removable dressing or device, but it can look like this if there's too much slough in the way, or it can look like this if you have too much eschar in the way, if you have just too much necrotic tissue. There's a good example on the heel there. Something that you want to know about the unstageable is that once the slough or eschar is removed, it's okay to restage these. So underneath that, it's assumed that you have a stage 3 or a 4 because it's definitely full thickness because of those full thickness tissue types. So once it's cleaned up enough, the clinician, your wound care provider, may just update the stage to 3 or 4, and you don't need to worry about that. Your unstageable went to a stage 4, it's going to look bad. The state perfectly understands that they're meant to evolve like that. It's not seen as a deterioration. Also, you want to keep in mind that if you do have stable eschar on the heels or on a distal extremity on the tips of the toes, stable meaning that if you palpate it, there isn't any pus coming out of it, there's no drainage, it just stays right in place. We don't want to remove that. And we also don't want to try to soak it off with our wound care, like apply a bunch of hydrogel to it and try to get it to like fall off. We don't want to do that. There is one main order that we use for dry stable eschar. Does anybody know what it is? What is it?
The treatment is using
Yes, betadine, exactly, yeah, that's what I'm looking for. floor, yeah. Betadine is the most common, skin prep is another common one, and it's just because it does keep it dry, and betadine kills the bacteria, so it's kind of a win-win with betadine. It doesn't need to be free of all slough or eschar to restage, just enough to be able to visualize the base. All right, so take a look here. There's actually going to be 2 unstageable pressure injuries in this picture. Which ones do you think they are? You can just call them out as you see them. I heard number 2. That's correct.
3.
So 3 is convincing. A lot of people want to choose 3, but it's there to just show you. We want to ask a little bit more questions about 3. So check it out. There's kind of 3 satellite lesions here. There's this one, and then a little one right here. So already I'd be thinking it's a little too diffuse to meet the criteria for pressure. I'd be asking a little bit more questions about that one. That is Coumadin-induced necrosis. So that's when somebody has taken a lot of Coumadin and they're now bleeding under their skin, and it leads to necrosis of the skin. So a little bit different pathophysiology. It looks like eschar, but we just want to kind of ask those kind of clinical questions a little bit further. 4 is the correct answer. 4, I would call that, I don't know, 80 to 85% slough. That's a lot of slough. Even though I can kind of guess that it's probably not a stage 4, it's a little bit safer just to refer to it as an unstageable until it's, much cleaner and I can really see the base. Okay, and our last special stage is going to be that deep tissue pressure injury. So it's a form of unstageable. It is a little bit of a heavier emphasis on shear. So these have a big shear component to them. So think again about when we're dragging somebody across the support surface and it causes that breakage of blood vessels. That contributes to the maroon, red, purplish discoloration that we see with DTPIs. So these are a little bit more ominous, like I said, than the stage 1. Our stage 1s we can heal in about 2 to 3 weeks with proper offloading, no problem. But a DTPI, even though it still has intact skin, the disruption of the blood flow these are expected to evolve and to open up because the skin is ischemic and it's not receiving enough oxygenated blood. So if you do see something like this and you're trying your best to offload it and do everything in your power to prevent it from deteriorating, sometimes the damage is already done. So if it does continue to evolve, these are expected to open up. And again, a DTPI that evolves into a stage 3 or a 4 is not seen as a deterioration by the state. So a lot of times people are fearful, oh my God, my DTI opened up, now it's a stage 4, we look like we didn't do our job, or maybe an admission came in with a DTPI and now it's a stage 4. Don't need to worry about that. The state doesn't recognize that as a true deterioration. But you can have intact skin with these or superficially non-intact, what we call epidermal separation. So you may just see a slight opening in the skin superficially for it to still be considered a DTPI. But if it does develop eschar or slough, then we would restage it to an unstageable. And if it does become full thickness and open up, we would stage it as appropriate as a stage 3 or 4. So yeah, that's a good DTPI right there. So you definitely want to examine the skin that is adjacent to the wound, especially in somebody that has a darker pigmentation. These can go missed all the time. There was a big research study just done by the National Pressure Injury Advisory Panel about how often somebody with a darker complexion has a DTPI and it goes unnoticed. Just because it's not this blatant color change like it is on somebody with a lighter complexion. So again, get your hands involved and feel the skin around this wound for any any temperature change, tenderness, what we refer to as bogginess or firmness, and it'll help you really detect these. All right, so take a look here. This is just kind of differentiating stage 1s from DTPIs. So number 1, what do you guys think? Is that a stage 1 or a DTPI? Stage 1, right? 2, DTPI, I think, yes. So 3, also DTPI. 4, stage 1. 5 is a little bit hard to tell from the picture, but it's just pink. But what about 6? What do you guys think about 6? Unstageable, excellent, yeah. So a lot of our nurses get the two mixed up and we see them called DTPIs and vice versa. So yeah, there's eschar, it's gotta be unstageable. 7 is on the abdomen though. What do you guys think about that? Not a pressure injury, right? Good, excellent, yeah. Didn't fit the criteria, but it's there to show you that things can be purplish in color and they're not all DTPIs, right? 8 we already saw. 9 is a good example of one on the metatarsal head of the foot. Okay, so just some things to keep in mind after today's session is that only pressure injuries are staged. So all of these nice staging tools that we just brushed up on, just make sure we're only using them for pressure injuries. We don't want to stage venous ulcers in the same way or diabetic foot ulcers. They have different classification and staging systems themselves. So just reserved for pressure injuries. We don't downstage our pressure injuries like we talked about. If a wound does reopen, we're going to refer to it as the deepest stage that it ever was based on the history. And you can just refer to it and say it's a reopened stage 3 or reopened stage 4. But if a wound does progress along the continuum and it does become a stage 4 from a stage 2, then it is facility acquired, unfortunately. Yeah. All right. So, I believe this is, yeah, our last slide here. So, as nurses, we are, really the front line of pressure injury prevention. It starts with us and finding these things at the get-go when they are just a stage 1 and preventing them from going along that continuum. So, yeah, even our biggest stages like this, are just intact skin stage 1s at some point or another. Yeah, do you guys have any questions for me? Did you have fun? Yeah. Okay, good. Did everybody get a staging guide? Okay, I'm sorry I kept you guys a little bit later. I hope you forgive me.